One moment, a very good day to all of you. It is a pleasure, as always, to be with you, sharing a little of the knowledge that I have acquired over time. On this occasion, I am very grateful to Dr. Fernando Carrillo Villaseñor, who is a third-year resident, for his attention. Also wanted to thank the organization Harvard Global Orthopedics for the invitation. I am glad for the invitation, and we are delighted to participate with you to learn something about the posterior decompression and stabilization of cervical spondylotic myelopathy. What are we going to do? My name is Jesus Bernal Marquez. I am a spine surgeon. I currently belong to the College of Traumatology and Orthopedics of the state of Mexico. My two background hospitals, the Lomas Verdes Traumatology and Orthopedics Hospital, where I worked for more than 20 years and then for a short time, but that was where I retired from the Mexican Social Security Institute, is the regional hospital of Villacuapan in the south of Mexico City. Let's see how we are going to reach diagnostic certainty. What is the natural history of this disease? What is the clinical study that we must do on all patients, the paraclinical study? Therefore, when are we going to operate? Based on what we're going to make the decision to operate on, some clinical cases, and the conclusions. Let's start with some very simple definitions, which is cervical spondylosis. It is nothing more than the degenerative process of the spine at the cervical level. It is a chronic process. It is a gradual, evolutionary process that leads us to the possibility of having a narrow cervical canal, as we are observing here, which can be in the central variant or at the level of the lateral recesses, could be at the foraminal level as well. The most common thing is for both to be combined, for it to be central and in the lateral recesses. The most serious, of course, is the one that is central, because this will directly affect the spinal cord, while the one that is at the foraminal level will affect the roots. This ultimately decreases the spinal canal and is based on the anatomopathological changes of the degenerative process. Osteophytes, thickening of the common anterior and posterior common vertebral ligaments, lack of flexibility, decreased height of the inner body space. All this leads us to the fact that compression can be exerted on the neural tissue. That's spondylosis. Now, what is cervical spondylotic myelopathy? Myelopathy, here we add, apart from the implicit commitment in the bone area, which is spondylosis, we are going to add a compromise of the neurological area, which is myelopathy, a disease process of changes in the spinal cord, that this leads us to neurological changes. One such well-known neurological change is upper motor neuron syndrome. We must know this with that attitude, because the diagnosis of this disease in 80–90% of cases it is purely clinical. Purely clinical. Obviously, it has to be confirmed by radiological changes, but the diagnosis is clinical. Natural history. Natural history. Notice that it's not recent. This was described by Clark and Robinson in 1956. Below we will have the references in case you want to write them down, where Clark and Robinson told us that in 75% of patients, it is a very slow stage progression. Over the passage of decades, even 2–3 decades in patients, and it's a very slow progression. The other 20% of the patients is a silent progression, but uniform, because the other 5% that is missing, and believe me, here I believe that we do fall short, according to Clark. In the 56 he said that it was the 5%. But more frequently, we see these patients arriving in emergency rooms with neurological loss, sensory motor loss, loss of sphincters, in a way that has increased to at least, I would say, to a 15–20%. It's not strange at all. What is strange is identifying it. We have to identify these patients. They must not suffer any fall, any blow. It is not traumatic. It is a degenerative process. And from one day to the next, they begin with problems with neurological clinical compromise. Let's start with some things in the radiographic clinical diagnosis. In clinical radiographic diagnosis, we always have to go in that order. First, the patient's clinic. The patient has a spinal column, he has neural tissue, we have to examine it, we have to touch it, we have to know the neurological examination. Then, we're going to take simple radiographic studies, both in AP and lateral, as well as dynamic ones. And in a moment, I will show you the obliques, and until the end, it will come, and always to the end. Never had MRI before. I have to highlight this, because now it's very easy not to even touch the patient, not even send simple x-rays and go directly to the MRI. See the MRI from our computer and do the seated diagnosis. No, we have to examine our patients, because I insist this is a pathology that we can definitely make the diagnosis clinically. We then also have to find out if the patient has chronic degenerative disorders or diseases. If there is thyroid pathology, we must weigh our patients. Obesity is not on our side if we are already looking at the surgical field, and above all, something that is very common. Smoking is common in our times. Smoking can harm us in the integration of any bone graft we may have. We go to the clinic for this. We need to know exactly what pyramidal syndrome is. Pyramidal refers precisely to our pyramidal pathway that we all see in undergraduate medicine, which begins in the cerebral cortex, in the motor area. This goes through many brain structures and reaches and is located precisely in the spinal cord. This pathway results affected all these neurological changes that are also called upper motor neuron syndrome. The upper motor neuron is nothing more than precisely all of our neurons that make up the pyramidal pathway. What are these clinical changes? Well, it can start with some weakness or even moderate muscle weakness, hyperreflexia. This is a sign that is very important to explore. For that, we had to have already explored reflexes for many years of our lives to know which is high, which is low, and which is the moment in which they are absent. If we give a young patient of 15-20 years old a percussion to identify the patellar reflex, he will jump a lot, and we will think that he is hyperreflexic. That is why we have to have that experience in exploring the reflexes, so that when a patient comes with real hyperreflexia, we can identify it. Clonus is very common in these patients, spasticity, and all the data from Babinski. In this case, the Babinski with which we explore and know how to explore is more than enough. Sometimes a slight small muscle atrophy is added or not. We have to question the patient in addition to exploring him. And for this, these authors, and here comes the reference in the European spine, tell us that the two evaluation scales that we should never stop applying are the Neuric and the scale of the Modified Japanese Orthopedic Association, which is here. Here the Neuric is very easy. They are grade 0, 1, 2, 3, 4, 5. Above all, this gives us the possibility of finding out if the result of the treatment we give to the patient, whether conservative or surgical, is on the right track. If we apply both, which is also very useful from the Japanese Orthopedic Association, it will be even more accurate. It is very common for patients to come to our office who tell us, no, it's just that I went to this doctor from that specialty and he told me that I have 3 hernias, 4 hernias, 2 hernias. That doesn't exist. That does not exist in the cervical spine at all. There would probably be discussion in the lumbar spine, but in the cervical spine, it does not exist. Everything is a degenerative process that I hope Dr. Fernando Carrillo will do us the favor of inviting us back. And we will talk to you about degenerative disc disease, which is very interesting. Knowing how our discs degenerate, what the degenerative process of the ligament complex is, we will know that it is impossible after 50 years of age to have disc herniations. When you have a degenerative process, it is called spondylosis, and here it can affect 1 or more levels. Spondylosis. While true herniated discs are in young patients, less than 50, I would say even less. 40 years, it usually causes neck pain. It can have delicate or serious neurological alterations. Radiculopathy is the most common, but it is always a single level that is affected. So this is very important to establish the difference. I insist, there are no 2, 3, 4 hernias. Right now, we are going to see the radiographic studies. It's all a degenerative process called cervical spondylosis. But of course, we have to make a difference with some other diseases. One of them is multiple sclerosis. Believe me, it is the main one. If we are in doubt if it is a myelopathy, if it is a sclerosis, it is better to request a consultation with the clinical neurologist so that they can help us by telling us if we are wrong. Well, it's just myelopathy, and that's it. But if we operate on a patient with a supposed myelopathy and it was multiple sclerosis, believe me, the evolution is not going to be satisfactory. Then, other pathologies that are a little clearer to establish the differential diagnosis are Guillain-Barré, cervical rheumatic instability, and tumors have certain differences from each other. The paraclinical protocol, since we have reviewed the patient, then now we are going to study the patient very specifically according to our neurological examination. We are going to ask for a complete preoperative profile. We are going to ask for a cardiovascular assessment. Remember that everyone is over 50 years old. We're going to request an evaluation for specific pathologies, cardiac, pulmonological, neurological, renal, which are now becoming more and more common. Radiographs always in this simple order, in AP, lateral, oblique, dynamic, until then the tomography, and until the end the MRI. If you have a very high clinical diagnostic certainty, then go and ask the patient for all the studies so as not to make him think so much. But if you still don't know exactly where the neurological examination is going, start with the basics, which would be simple X-rays. These are our simple X-rays, where we see that there is precisely a decrease in the interbody space, formation of osteophytes in the front, facet osteoarthritis in the back, even correction of lordosis. Here, it is practically erect. There is no longer any space in 1, 2, 3, maybe 4 levels, and practically 5, that is, the entire cervical spine has a process of spondylosis from the simple X-rays. The obliques will help us see the foramina. Here, look how the foramina are. Good, quite good. It is an X-ray of a young patient. This one perhaps already a little diminished, but the one on the other side definitely more diminished. So oblique X-rays will always give us a lot of interesting data. MRI. MRI, since it was invented, since it has been used in medicine, believe me, it is the best way to have diagnoses of the spine. There's no other way. It far surpasses all other studies, including one that I haven't even been mentioning to you, which is electromyography. The electrical study, personally, I no longer request it. The clinic is much more accurate than the electrical examination with electromyography. And now if we go to the nuclear magnetic resonance, well, we are going to see here the spinal cord, how wonderfully over time it adapts to the anatomical changes of the spinal canal. But the moment comes when precisely this loses vascularity. It loses vascularity, and that is called ischemia. Remember that the neural tissue is very sensitive to changes in oxygen. The oxygen drops. Immediately, we are going to have alterations in the neural change, in the neural tissue. Therefore, the fact that oxygen is decreasing over time will give us clinical changes in the patient. A very important finding in MRI is this, which is the hyperintense change in the T sequence of the MRI, which is called myelomalacia. It's a fairly common change. It's not cerebrospinal fluid. It speaks of a spinal cord ischemic process. This author below is Bapat, of Hindu origin. He talks to us precisely about the patterns of cervical compression in the POC, and this is what he reports. As POC goes from 1 to 5, he sees how degenerative changes can modify the cervical spine of our patients. Obviously, it will depend on what stage we are seeing our patient. Today, we can see a patient with a POC4, but tomorrow, we can see a patient with a POC1. Every patient is different on MRI, which is where this is evaluated. In POC1, for example, we're going to see partial or total compression, but at a single level, while in POC2, we already see compression at 2 levels. And to quickly compare it with the POC5, here we already see changes at multi-level, as we are seeing in the POC4 in 2-3 levels. But the difference is that here, there is already a correction of the lordosis, and it's not only corrected, it is corrected here. It is corrected here, and it is corrected here. At point 5, we already have a reversal of lordosis, and it becomes kyphosis. This will also give us parameters to know how we're going to act. And precisely this same author tells us that according to the POC that we find in the changes in the MRI, we can decide. It is a guide. Remember, they are not recipes. It is a radiological clinical guide. A POC would indicate to us that we can enter a decompression via an anterior route, while in the POC things change, because the POC, here we are going to take another factor into account. The other factor is called ASIA. It is the preoperative assessment. That is why it is so important, because the higher the degree of ASIA the patient has, and the higher the degree of POC, the preferred decompression will always be the posterior rote. So once we identify cervical spondylotic myelopathy, we can decide that if it is intermediate or not so progressive, we can give it conservative treatment. If conservative treatment fails, move on to surgical treatment. If there is a good response to conservative treatment, we can defer it as long as possible until after a while it may fail, and then it becomes surgical. Patients with a moderate but progressive or even severe or acute alteration, as we were seeing previously, can directly be scheduled for surgery to perform a decompression that can be anterior and posterior, or only posterior. Remember that it is not putting up plates. In the world of orthopedics, it's always very common. Why do you like it? It's a plate, it's a nail, it's a screw. It is not putting implants in the spine. It is not putting implants. It is knowing why we are going to operate on the patient. One of the main characteristics is to perform a neurosurgical decompression. That is, under surgery, we're going to decompress neural elements, we're going to recover normal lordosis, we're going to do a fusion, we're going to stabilize that segment so that the patient has early mobility. We have to meet all of these objectives in one patient, in several patients, or perhaps 1 or 2 objectives in a special patient. Each patient must be assessed differently. Here we have a patient who precisely had a myelopathic problem. He could not walk on his own. With difficulty, he could hold on to the walker. These are your plain X-rays. It was decided to operate via the anterior approach, removing 1-2 vertebral bodies. Apparently, well, with a good clinical imaging result, since the patient was doing very well, but it is one of many alternatives when there are already more than 2 levels, as we ended up doing. That is to say, there is a need to decompress. I suggest, and the authors also suggested, the posterior rote is better. Here we are seeing precisely an image, how we see the dural sac, because it is the dural sac, and below the dural sac the cerebrospinal fluid, and how the spinal cord is by translucency observed here. So the posterior route is this, where we are going to remove the laminae from 1 level, 2 levels, or hemilaminectomy from 1-2, or up to 3 levels or more. I believe that it is a procedure. It is not simple, nor is it that complex, but its manipulation is very delicate. Of course, one of the problems why it was not done before, with as many patients as we needed to do it at the time, is because we did not have the appropriate posterior implants. Now, we have had this posterior implant for some decades, at least 2 decades. The screws can be fixed through the facets or through the cervical pedicles. And believe me, it has been something that has revolutionized the treatment of the cervical spine. Because thanks to this, we avoid leaving the patient unstable with our decompression. That is, with decompression, the patient is left unstable, but thanks to the implants, they help us maintain stability by adding a fusion. Here, we are seeing the result of 2 levels of decompression. These are the intraoperative images, and these are the images at the end of the surgery. Screws placed in transfacet pathway. We are seeing the clinical case here in a patient who is only 68 years old. We do not expect to find this in patients who are 70, 80 years old. Sometimes we can find it in even younger patients. Another clinical case. Here we are removing 1, 2, and part of the 3rd lamina. A very extensive decompression, very adequate. They're implants placed in such a way that they help us maintain stability. But remember that the implants only maintain stability temporarily, while the body has its fusion. We have to help them. In this case, we must help the patient. We must help the body with a little protein, bone proteins, in this case, bone matrix. Why don't I not recommend the anterior route? When we have more than 2 levels, and this is one of the cases, even in a single level of decompression with an apparently well-placed plate, we can present instabilities of the implants, and therefore the patient may fall into kyphosis. We can increase our decompression level to 1, 2, 3 vertebral bodies. This generates very large, very long lever arms on the plate, and therefore the patient may have a process of instability of the implants. And that is precisely what happens. Even if we have Bob's graft, iliac crest graft, cages, or even autologous graft, with the plate the screws break due to the efforts at the level of the implant. You can even undock the cages when they are more than 2 levels. Here, they were 1 body, 2 vertebral bodies, and it's a disaster, because now we have to stabilize this patient through the anterior approach, and perhaps he will require decompression through the posterior approach anyway. This is exactly the message I want to give you. We cannot go to a congress. We cannot observe this conference, and tomorrow I will operate. No. Everything involves a learning process, and what we should never come to is this. They told me to put a plate. I put a half-tube plate with 2 small screws, and this is even more disastrous in the patient's exposure to surgical risk than in the X-ray, which is already about to be said. This is the previous shot. It's a very small plate. It is from fingers. And this is what we should not end up causing harm to our patients. We must always do it with a lot of knowledge of what we are going to do, calculating the risks, calculating the benefits, to always be able to offer our patients the best treatment. Conclusions always follow a complete study protocol. They never ask for nuclear magnetic resonance at the outset. Always simple X-rays first. Making a differential diagnosis, a comprehensive diagnosis, the right patient is what gives us good results. If we choose the right patient, the results will be very good. The correct route based on the radiographic studies and the implant that will always help us. Thank you very much for your attention. Thank you very much, Dr. Carrillo, for